So I am Stephanie Cross, and I work for Washington State Department of Children, Youth, and Families, and I do research with our juvenile rehabilitation population, so our juvenile justice clients. Mostly, the majority of my work falls along SUD needs and treatments, the assessments that we use, and lately I'm getting into some mental health research and co-occurring disorders. So if you follow along the program, you'll notice that this is a little bit different than what's in the program. This is a little bit more of an updated presentation than what's in the program, but I'm happy to send the report of what's in the program to anybody who's interested in seeing that one as well. But this has a lot of the similar results. So let's see if I can figure this out. Here we go. So the purpose of this particular research paper was to identify the extent to which JR, which is our juvenile rehabilitation program, is appropriately matching treatment to need for our clients, and to examine what factors may predict whether or not a client received substance use disorder treatment, mental health treatment, or both treatments. So if they have a co-occurring disorder, they should theoretically get a mental health treatment and a substance use treatment. So my study population was clients who were released from a JR institution. We have 2 in Washington State, or a community facility, which is also a state-run rehabilitation, or for juvenile justice clients, they can go to a community facility where they're allowed to leave and go to work and that sort of thing, with lots of rules and regulations. So my population consisted of clients who were released during our state fiscal year, which is July through June of 2017 to 2019. And that was 1,376 clients. So one of our assessments to determine mental health treatment need and substance use treatment need is called the GAB-SS. And if you're not familiar, the GAB-SS is the global assessment of individual needs, and the SS stands for short screener. There's a very long one. Since we're dealing with a juvenile population, we try not to overrun them with too much paperwork and assessments and questions, because they're already stressed out when they come to us. And so we use a short screener, which is only a few pages long. It only has 3 sections. So I used the results of the GAB-SS to determine if a client has an SUD, mental health disorder, or both, and then whether the client has a treatment need. So to determine whether or not they have a need, I look at the score. The score that they can get on the GAB-SS ranges from 0 to 5. In JR in Washington, we have historically used a score of 2 or above, so a 2 to 5 to determine a need. I have been working very hard over the last couple years to use a score of 1 to get further assessments, because even if an individual, especially a young client that we work with between ages of 14 to 25, if they score a 1, there's still an issue. So, and even if they score a 0, we oftentimes out there's still issues. As I'm sure you can imagine, a lot of these young clients aren't exactly truthful when they come to us. And in filling out these forms, the GAB-SS in particular, we give that to them within 48 hours of them entering our institution. And so for the first timers, you know, they're nervous and they're scared, and they say, oh my gosh, if I say, yes, I've done heroin 5 times in my life, I'm going to get in more trouble. So they're not really filling out these forms accurately, which is also a big issue that I deal with. So moving on, I also used what's called the CAST. And for the life of me, I cannot tell you what that stands for. But it is a system within our administrative data in our JR that we use to track any kind of education or treatment programs that are being given to these clients, and hopefully the outcome of that treatment. Although I'm not going to get on that soapbox about how awful our data is. So I use that, which, tracks all the treatments to determine if any previous substance use disorder, mental health treatment, or a combination of both treatments have been given to the clients. So demographics, and I'm sorry if that table is small. So you'll see in the table it says study, and that's my study population. And then alongside that is a column that says all. The reason for that is that I excluded clients who were immediately serving another JR sentence. So they were technically released from our institution and then immediately went back in to serve a different obligation. I excluded those individuals, and I also excluded individuals who were transferred to a DOC facility. So in Washington State, we keep clients who were convicted of an adult crime until they're 25. So we keep them in our juvenile system until they're 25. On the last day of their 25th year, they either continue their sentence in a DOC facility with actual adults, or they're released if their sentence ends there. And the purpose of that was to try to not expose them to that adult population for as long as possible, for lots of various reasons. So you can see that the majority of the clients in my study population were males, which is true for a lot of incarcerated institutions, incarcerated people. The majority of them are often males. The majority of our population is white, either Black, African American, or Hispanic and Latino. The average age of my study population was just under 17 years. And as you can see from the two columns, like I said, they kind of mirror each other. So I feel like I wasn't overrepresenting or underrepresenting any one particular demographic in my study population. Also, I should say that these clearly are not the only race and ethnicities that are available. However, for various legal and reporting reasons, I can't report out really small populations because those folks can then be identifiable if you were to try to do that. So 34 clients were removed from this table because their status of race or ethnicity was too small or unknown in the data. So the GAIN-SS, like I said, the Global Assessment of Individual Needs, has 3 sections. 2 of them are mental health indicators, and 1 of them is an SUD indicator. So you'll see in the table, ID is internal diagnostic screener, so it's a mental health indicator. And then there's external, which is also a mental health. And then you have SUD. So these columns are mutually exclusive. So in the ID column, those are clients that only had a score in that ID section. The ED column only had a score on the ED section, and so on and so forth. The CD stands for a co-occurring disorder. So they had scores in both or one of the mental health sections and the SUD section. And the majority of each racial and ethnic group fell into the co-occurring disorder category, which is not surprising with the population that we're dealing with. They're coming from trauma. A lot of them are arrested because of drugs. They have a lot of mental health issues before they even come to us, or sadly, they develop them after being in our care for a while. And only 9.3% of all clients had neither a mental health disorder or a substance use disorder. If you look at table 3, this is just broken down by gender, female, male. We tried to be more inclusive of different genders. However, given the population and the closeness that these people are living, they're not often truthful or honest, I guess, or forthcoming with what they might want their gender to be. And so we just stick to female, male, and they can fill that out as they see fit. But the majority of each gender group fell into the co-occurring disorder category, once again, not surprising. And males have a higher percentage of substance use disorder than females. And females have a higher percentage of internal indicators, while males have a higher percentage of external indicators for mental health. So that's more acting out, it's fighting, it's your typical boys sort of behavior, right? They're more aggressive in general, and so that's more seen externally. So next I look at treatment, and table 4 again just breaks it down by race and ethnicity. So we have substance use disorder treatment, mental health treatment, combination of both or none. This other category is interesting. to me because I found out that from the GAIN-SS, they might say that they have a substance use disorder, but get no substance use disorder treatment. They only get mental health treatment or some other kind of treatment. So this other category is they're getting treatment other than what is indicated as a treatment need on this particular assessment. And the majority of clients who indicated treatment need did not receive any treatment. As a state-run facility, these are people that we are supposed to be taking care of, rehabilitating, which is in our name, and we are not providing them the treatment that they are showing that they need, which is a big problem. Also found that Asian Pacific Islanders are more likely to receive substance use treatment, while all other race and ethnicities receive treatment for mental health needs, or both substance use and mental health, most frequently compared to substance use treatment alone. Table 5 just again breaks this down by gender. Females are more likely to receive both treatments than mental health treatment or SUD treatment alone, and males, on the other hand, are more likely to receive mental health treatment than SUD treatment or both treatments. Again, this mental health treatment for males is most likely due to what we saw on the last slides, that they are more external in their treatment needs, and so they're more easily identifiable to caseworkers and that sort of thing because of how they're acting externally, if that makes sense. So I ran a couple of regressions just looking at each treatment separately. So this table 6 looks at the odds of receiving substance use treatment. For my independent variables, I use those 3 sections in the GAIN-SS, again, the internal, external, and substance use sections. And I had a variety of control variables, gender, the different race ethnicity categories, and those are all in comparison to white. The sentence type, again, we have a juvenile sentence or an adult sentence, and their length of stay. So as length of stay gets longer, whether or not that increases their chance of receiving treatment. So again, this is just for substance use treatment, and the results indicated that as the external GAIN-SS score increases by 1 point, the odds of receiving substance use treatment also increases by 10.5%. What I think is happening here again is that these clients that have more external factors are more visible to staff, more visible to their caseworkers and that sort of thing. And so they're actually being engaged with more often. And then these substance use needs are coming out at a later time. I also found that as the substance disorder score increases by 1 point, the odds of receiving substance use treatment increases by 39.4%, which is great. It really should be higher than that. And then gender was the only statistically significant control variable, where males were more likely to receive treatment for substance use than females. So the next regression I did was just looking at mental health treatment. Same independent variables and same control variables. And what I found was that as the internal GAIN-SS score increases by 1 point, the odds of receiving mental health treatment increased by 12.2%. And there were 4 control variables that were found to be statistically, there we go, significant for receiving mental health treatment. And that was gender. Again, we saw that the females were more likely to receive mental health treatment. The age at release was they get older. As they're approaching their release date, they were more likely to receive treatment. Black African American clients were less likely than their white counterparts to receive treatment. And sentence type, if they had a juvenile sentence, they were more likely to receive treatment. And then lastly, I did a regression looking at both substance use and mental health treatment. And I found that as substance use score increases by 1 point, the odds of receiving both substance use and mental health treatment increases by 27.2%. There's nothing surprising here. As they have an indicator for substance use, they often will have an indicator for mental health treatment. And so it makes sense that they are more likely to receive both treatments. None of the control variables were significant. So what does any of this mean? Well, we found that the majority of clients in the study with an SUD or a mental health treatment need are not receiving treatment. Again, there was 51.5%. That's 627 clients that we did not touch that had a clear indicator for a need. This is also could be overstated because if they did receive treatment, we know that it's not being adequately tracked. In our record management system, there are some issues with receiving community treatment in our community facilities aren't often being recorded like they should be. So we're working on that. Also found that 22.5% of clients that scored a 0 on all GAIN sections. So that means they're indicating that they are perfect, right? They have no mental health issues, never touch a substance in their young lives. Later, we're finding out that they actually are receiving treatment. So this could be an issue with the assessment that we're doing. This could be an issue with the timing of it. Like I said, you have a 14-year-old coming into our institution. We're shoving all this paperwork at him, asking him or her all these questions. I know when I was 14, I wasn't going to say the stuff that I was doing, because why would you get yourself in more trouble? They don't understand that we're doing these things so that we can hopefully help them in the long run. So that can be a big issue. So the GAIN SS in our system, our social workers and our clinical staff don't use it regularly to identify mental health needs. They use it mostly for substance use disorder, although it is for mental health treatment needs. So that could be an issue. And we're working on figuring out why the caseworkers and assessors and that sort of staff aren't using this as a mental health indicator. And then, like I said before, not all treatment that clients are receiving is being recorded in our system. Again, this could be due to community facilities. A lot of times I will go in and I will look at what treatments are being provided, and we gave John Smith 3 different substance use treatments and a mental health treatment 5 years ago, but we've released that person 2 years ago, and it still says that they're in treatment, which is not a possibility because they are not under our jurisdiction anymore. And so there's a lot of study limitations due to data. So working on that with my JR folks, and then so I came up with some recommendations for kind of steps to move forward and more things to look at. We need to clearly outline the pathways from assessment to treatment, and then monitor that pathway regularly and just make sure that that is being followed. Clearly state how these assessment results inform treatment decisions. Why are there folks scoring 0s and then getting treatment, where there's folks scoring 5 and getting no treatment? So what is happening? The assessments and the treatment should be connected with clear pathways between assessment, treatment type, and then dosage of treatment. Are they coming for one day? Are you giving up on them because they're being difficult and saying they don't want to be there? Are they completing it? Are they just sitting there twirling their thumbs? So what sort of dosage are we doing for this individual that is going to be give this person the best outcome? And then document a quality assurance plan for our substance use and mental health specific assessments and for the treatment provision. So create a clear policy of how and when assessments occur, ensuring all clients receive the assessment in a consistent manner. So again, this kind of goes back to our data quality. The GAIN-SS is one of the state required assessments that we are supposed to give every client when they walk into our door within 48 hours. We still have a good percentage of clients that aren't even getting that assessment. If they do get the GAIN-SS and they have a clearly indicated need for either further assessment or for treatment, a lot of times that further assessment isn't even occurring. And so they just get the one form and then nothing is occurring after that. So we need a better plan. We need to monitor treatment that is occurring. and consistently and adequately produce quality documentation about the treatment. That way we know what is happening, what is working, who is getting which treatment and why. And then design and implement reporting to support those first two recommendations. The reporting will allow leaders to identify if and when an issue with the assessment to treatment system or pathway has occurred, and to allow the issue to be corrected. I know that was really fast, sorry. But thank you for listening to me.